How's everyone doing? This is Luke Tomich with the Epilepsy Institute of New Jersey. I want to talk a little bit today about SEEG. We've now placed several hundred depth electrodes on patients over the last 5 years. And this is a really powerful diagnostic surgical procedure that allows us to sample extensive parts of the brain, sometimes on one side, sometimes bilaterally, to better understand the seizure onset zone and what we call the epileptogenic network. In other words, areas of early spread. Again, this is a very powerful diagnostic procedure that we put our patients through. I would say the majority of patients today in the United States will get a two-step epilepsy surgery where SEEG is the first step. But SEEG also has its drawbacks and limitations. One of the things that we struggle with is what we call sampling error. So in other words, we need a hypothesis of where to implant, and we use a number of non-invasive diagnostic tests to do that, including MRI, PET scans, SPECT, MEG, ESI, electric source imaging. All of these we have available here in New Jersey. But not always, even from all those studies, do we have an exact understanding of where the seizures are starting, so sometimes we have to do relatively broad implants. Additionally, probably in about 10% of patients, after the first implant of depth electrodes, we might supplant or include a few additional depth electrodes in an area of interest. So for example, if we're still trying to lateralize the epilepsy, understand if it's right side or left side, we might start with a montage of depth electrodes on the right side and a matching montage on the left side, and then only after finding that it's a right-sided onset, we might put additional electrodes, let's say in the right frontal lobe, to better understand exactly what areas are causing seizures. So I want to talk about that a little bit because it has become an almost indispensable part of epilepsy surgery to start with first step SEEG.